Hi, everyone. You're live on LinkedIn with Drummond. We have a few people joining here. I'm with Tim Bennett, and we're here to discuss our first impressions of ONC's new HTI-2 proposed rule, which recently came out, and we'll be talking about what that means for health IT developers. I'm Bob Bryan. I'm the Senior Director of Health IT Advisory Services at Drummond. I lead the team that provides health IT organizations with consulting services to help them plan and achieve compliance with health IT criteria issued by ONC, and particularly looking at currently HTI-1 requirements and the coming requirements that we'll have in HTI-2. Which we'll be discussing today. Tim, you want to introduce yourself?
Yeah, sure. Thanks, Bob. For folks that might be tuning in that don't know me, I'm Timothy Bennett. I am the Director of Strategic Healthcare Initiatives at Drummond. Currently, I lead the development of new testing and certification programs that is focusing on the HL7 fire standards and interoperability, conformance. Before this, I led the ONC Health IT Test Lab at Drummond as part of the ONC certification program, and as part of that, I've been involved in testing health IT since 2010. I'm also a governing board member of SHIFT, which is a healthcare task force of industry stakeholders that's focusing on ensuring interoperability that is fair and impartial, patient privacy and consent and things like that, and honestly a myriad of other things, including work in the public health field for testing and certification, immunizations, pediatrics, starting to work on mental behavioral health. So my role here at Drummond is really covers a lot of the healthcare ecosystem across the board. Bob, you ready to?
Yeah, let's dive in.
HTI-2?
We got the 3,000-page release from the ONC a few weeks back.
Meaty.
And they've done a few sessions on it. Any initial impressions that you have of the new proposed rule?
Yeah, I mean, my take here on HTI-2, it's a bold and ambitious proposed rule. Beyond just it being thick, 3,000 pages plus, as you mentioned, but the really interesting parts, particularly in sort of my purview here with fire and conformance and interoperability testing, is that I think really for me, there's some precedent setting aspects to this rule. I think for the first time we kind of see in proposed rulemaking, ONC sort of branching out beyond its sort of traditional focus on EHR developers and that serve the provider market, branching out to establishing criteria that covers other entities and stakeholders in health IT, such as payers and HIEs and even potentially entities within the public health space. So I think I'm sure we'll get into this more in our talks, Bob. In that aspect, for me, it's a really interesting rule.
Yeah, I spend a lot of time consulting with EHRs. Right now we're mostly talking about decision support interventions under HTI-1 with a deadline at the end of this year. But my initial impression as I started to look at some timelines is that this rule fills up another 2 years after customers finish up with the HTI-1 requirements this year and next year. It takes us into 26 2026 and 2027 with new sets of requirements that are going to need to be met. And I guess my other impression is that, with fire, when ONC rolled out the G10 rule, I heard Dr. Tripathi speak at one point, and he said, we wanted health IT developers to get started with fire. So they put out the patient population services rule, which is a read-only fire API. But now we've started to see more fire, not specifically required, but certainly the glide path for decision support apps and predictive decision support in particular that needs to access the US CDI data set. But now with this rule, we've got prior auth coming. We've got new fire standards. We've got multiple actual fire APIs that are specified. So I think fire is finally here.
Yeah, for sure. I mean, I think, this proposed rule, HTI-2 proposed rule, sort of stands on the shoulders of some of the foundation work that was laid with the Cures rule, and built upon by HTI-1, and really aligns with the recent rules from CMS. So I think you're right. I mean, those prior rules, the Cures rule and CMS's first interoperability patient access rule, both of those, sort of were published in 2020, and really for the first time established, some fire standards for both payers and providers, EHR developers, to make patient health data available to them, enable patients to get access to their health information through, smartphone apps and other apps that were connected to these fire APIs that payers and providers are required to, stand up. But CMS's 057 rule that they released earlier this year, and now with the proposed rule from ONC on the HTI-2 rule, there's some adoption and reference and recommendation of more complicated fire APIs that are, are what I call beyond patient access, and these are really going to embody some complex workflow-based operations of health data sharing at a completely different level of complexity than patient access. And so I'm sure we're going to get into those details, but this is definitely continuing and building upon the prior rules. But I think for a while I kind of talked about patient access sort of being the tip of the iceberg, and now we're starting to get below the surface and see this bigger vision of fire-based health data exchange.
Well, and when I look at the timeline for the rule, of course, next year there's a series of requirements that EHR developers need to meet under HTI-1, but 2026 looks like the year of prior authorization, and that is the big criterion that's been put out there. And of course, we came in even before HTI-1. We knew that CMS had deadlines set for January 1st of 2027. So that meant that really payers and providers were already on a path towards prior auth. But now we have specific ONC criteria. And for the first time, we have criteria that actually apply to the payers. And that's pretty interesting as the ONC extends this program out to developers sort of beyond the ones that are directly serving providers. And I know, yeah, I mean, you've worked in the payer space and have managed a program already at Drummond for payers. What are your thoughts about us actually having the prior auth rule and specific rules for payers and providers out there now?
Yeah, I think, there was sort of a gap in prior rulemaking from ONC and CMS around the FHIR APIs for patient access. The gap being when the Cures rule came out in 2020, established certification criteria directed at EHR developers primarily, um, and those, the implementation by EHR developers and by providers was incentivized by CMS to, to use and be required as part of participating in MIPS and things like that, to support these patient access APIs. And so we saw, a big uptake there in EHR developers getting certified for their FHIR APIs that service providers and their patients. Likewise, CMS did the same thing for payers, that they had to stand up these patient access APIs so that members of health plans could have access, through their payer, to have access to not only their clinical data but their claims data through these FHIR API smartphone apps. But the difference here was that while ONC, had a certification program for the, for the EHR developers for these FHIR APIs, CMS didn't have that same, certification program. And so sort of what's developed here over the last, 2, 3, 4 years is that you have sort of one side of FHIR developers having a strong incentive to get tested and certified, while the other side, the payers, didn't really have that. And so Drummond
there's no path for them, really.
Yeah, there was no certification requirements. I mean, there was requirements by CMS for payers to implement it, but not a way to really verify by testing and certification that the implementations were compliant. And so Drummond saw that sort of gap, and we stood up a conformance testing program for payers and patient access, using test tools in the marketplace. And so like the Aegis Touchtone tool, and made that kind of testing and certification available for payers and developers of payer solutions. And while that, some in the marketplace took advantage of that, it was still voluntary, and it's not, was not really incentivized in a strong way. And so I think what now we see is that there's a recognition of that by both CMS and ONC. And so the HTI-2 rule, I think, proposed rule now establishes sort of this pathway, this roadmap that will enable, a more federally regulated testing and certification criteria, to be established, for payers and other entities. And quite frankly, that's going to be needed. I mean, I don't want to take away from the importance of patient access, but it's not nearly as complicated a FHIR APIs and data exchange as some of these sort of what I call next generation beyond patient access FHIR use cases, like prior authorization, like payer data exchange, and even patient or provider access, and then I think there's some more use cases coming down the road.
I mean, I saw the big three from a sort of EHR provider perspective being the provider auth requirements for a FHIR API in 2027, or in really needs to be worked on and finished in 2026 and ready by the start of 2027.
Yeah.
And then in 2027, to be ready by January 1st of 2028, you've got two more APIs, which are the provider access client that has to be available from the EHR provider side,
Right.
and then the public health API as well. And so 3 big new FHIR use cases coming in, and then we have these parallel rules that are hitting the other players besides the providers, that the payers can access. And then really, I know they're talking about the HIE HINS community also, particularly in the public health space, having some rules that are available to them. So it's interesting that we've got more of the players that are in the world of interoperable healthcare now actually having access to clear certification standards.
Yeah, sort of these use cases now are enabling standardized ways for providers and payers, and providers and IHEs, payers and IHEs, all these different stakeholders, in the health IT ecosystem, to have these electronic conversations with each other, that are going to embody sort of these complex workflows that are going to have multiple messages that are going to go back and forth. Prior authorization is certainly an example of that, where there's multiple sort of messages that are going to go back and forth to complete that that workflow as part of a prior auth request, and all the documentation requirements that sort of providers have to submit. So these are multi-step, multi-conversations, and so the degree of you can't really just expect that to work if only one entity within those conversations would be tested and certified. And I think what we see here is that CMS and ONC recognize that, and so now this is a path where all the participants, or all the players in these sort of more advanced FHIR conversations, all the different applications can be tested and certified. And so I think that will ratchet up the chance that we can have interoperable solutions on all sides of the conversation, these electronic conversations.
Yeah, I mean, it really feels like community testing is going to become more and more important in this world, because everybody's going to be working on these connections at the same time, and maybe on somewhat different schedules for multiple APIs, but particularly prior auth, which is going to be that early deadline. And I know you've been working on a community testing approach at Drummond. Do you want to talk a little bit about that?
Yeah, so one of the things that we recognized at Drummond, and this sort of goes back to 20 plus years of experience at Drummond, so even sort of back to our roots before we even got into health IT testing, a recognition here internally, and something that we are very aware of, is that conformance testing and testing solutions with test tools that make sure that you have implemented the standard in a compliant way, that's certainly very important. Without the standards and without a way to sort of test conformance, there's no chance of having interoperability. And so this goes a long way for products if they can do some conformance testing. But the thing that we knew and we discovered from our work in the supply chain and in the B2B space, where you have trading partners like Walmart and all their suppliers that sort of use these secure data exchange standards to exchange EDI documents, purchase orders, invoices, all sort of the back-end business documents. We knew from assisting and enabling and facilitating that domain and being interoperable, trading partners having interoperable software made by different solution providers, but they all work together because there's interoperability testing among them. We knew that from our long experience doing that this was going to be needed for health IT data exchange, is something beyond conformance, because conformance alone doesn't really guarantee interoperability, because while that goes a long way, as I said before, being conformant, there's so many other variables when we start talking about these robust, complex solutions having to speak with one another electronically and be interoperable. There's so many other factors involved that determines whether you're interoperable or not. Everyone has a IT stack, hardware, and software, and you just have the internet with firewalls and with all kinds of people implementing standards and interpreting them in a different way. And if they're not specified very clearly, there's just lots of barriers to interoperability. And what we know and what we recognize is that until you actually bring the solutions together, especially these complex solutions that are workflow driven and have a lot of business logic in it, until the products themselves, the solutions themselves can actually test with each other, you're not really going to approach full interoperability. And so when we see with prior auth, you have EHRs, you have providers, you have payers and their solutions that they've developed, and there could be other entities mixed in. Unless we're doing real testing with the products themselves, you're not really going to guarantee that there's going to be some interoperability. And so we've adapted our methodology and our technology that we've used in the B2B space for 20 years to do interoperability testing there. We're bringing that into health IT and the fire space. We call it Fireplace, and really what it is a combination of a testing methodology and some automation, so that we can facilitate the actual products coming together that are deployed in the real world and actually testing with each other. Every product, every role and entity doing full testing with each other, and then able to run thousands and thousands of tests across the whole workflow and the whole IG, the full scope of the IGs that are involved, and so that's really where I think Drummond's strong role is being that sort of facilitator, bringing products together and enabling them to test with each other. It's kind of being done a little bit, Bob, at a small scale. Folks are peeling off and doing pilots together. But what we envision here with Fireplace is that we can bring tens or scores or even more of these products together and do massive scalable testing. And we really believe that unless you have that sort of level of interoperability testing, to expect to roll out these complex solutions for prior authorization or payer data exchange, or in the future patient cost transparency for the No Surprises Act, it's not realistic to expect those things that were developed in a silo just to magically work together when the deadlines approach, right? We have to have some well thought out methods for doing this kind of scalable testing.
Yeah, and I meant to mention earlier, if anyone who's on with us now does have questions, please feel free to submit them in the chat. and we'll either pick them up while we're going through this or catch them at the end. Yeah, so I mean, I see this area. It's a testing step, particularly in that one-to-many scenario,
Yeah.
particularly between providers and payers, and the payer-to-payer use cases, that it will actually allow that final testing of the real implementation that's in place, particularly I think for providers, who, we know with these deadlines um, we've got EHRs that will need to have the provider side built by the end of 2026, but then there's implementation by provider organizations, and then the connectivity that they're going to need to actually see with the specific other parties that they'll need to connect with in these prior auth transactions, ultimately also in the regular provider access transactions with payers, and then we've got the public health use cases down the road too,
Yeah.
that are a significant part of this rule. So it seems like 2027 is a long ways away, but I don't know.
Yeah. So I think one of the other things about, our idea here around Fireplace is, it's not really just geared towards once everybody has their compliant implementation completed, you come and you do some testing and you sort of get certified. That's sort of kind of been the model of,
Right.
of ONC certification. What we recognize here, and I know, Bob, your customers, I think, when you talk to folks that you are advising and helping to be compliant with the regs, what I know from our experience in the B2B space, and I know that folks, whether they're on the payer side or whether they're going to be on the provider side, EHR side, that are going to be implementing things like prior authorization, how are you going to know as you are developing, as you are implementing these very complex, uh, even before the deadlines, how are you know that you're developing it, that it's going to work with other solutions, ones that you're going to be talking about? And when you mentioned the sort of community aspect of our idea here around Fireplace, Bob, that's exactly what we're trying to establish, is that we're not expecting you to come and do interoperability testing with a pristine gold standard prior auth implementation. We know that it's going to take a lot of time for people to get there. And this will actually facilitate folks being able to come, and as you are developing, as you're implementing, pieces and parts of, something as complex as prior authorization, you're going to have others that are doing that same thing in other organizations. You will be able to come in a sort of a safe, neutral, safe place where you can test your implementations with others. I mean, it kind of takes the connectathon concept and sort of pumps it up with steroids, if you will, and the scale factor is much bigger. I mean, these connectathons are very important when you're getting started, but I think you need something more than something that just happens a couple of times a year with a small set of other participants. So anyway, I think your customers would find value in knowing that, as you're advising them on how to implement these prior auth standards and other criteria, that there's going to be a way for them to be able to test while they're implementing.
Yeah, I mean, I think to understand the complexity from the provider side, I recommend that providers specifically look at the G34 criterion that's in the proposed rule, with the understanding that their customers already have a CMS measure in place to do prior auth transactions in 2027. So everything needs to be in place by then for them to be able to actually do transactions and meet that measure requirement. Which, I mean, that rule was already out before we got HTI-2.
Right.
And, and there's another part of HTI-2 that I wanted to make sure we got to, and that is some of the modular breakdown that we see here, which I think is pretty interesting, because we've got breakdown in a number of areas. In the public health space, we've got these specific rules for different types of public health reporting transactions, and we've got the two sides covered. We're also seeing it really kind of a breakdown of the APIs into some very specific functions in the new J rules. And it feels to me like these breakdowns are going to enable more third-party providers to move into the space and specialize. And what I'm not completely sure about is what the packages of functions will be that the third-party community decides to adopt and certify to. But it's really interesting that the way that the ONC has broken down these rules and kind of modularized the program somewhat more, which I think is aligned with some of the direction that health IT is going in general.
Mm-hmm. Yeah, well, these these more complex rules are going to mean that there's parts of the workflow, I think, that are going to be able to be there'll be sort of specialized solutions to just do part of that in a very good way, and that will enable buyers and users to sort of piece together a complex solution by perhaps assembling best of breed. And so I think these rules sort of recognize that you're going to see perhaps solutions that focus on identity management or focus on CDS hooks, elements, some of the more supporting elements that sort of make the whole process go. And I think especially when you start talking about prior authorization, you have multiple IGs are involved in that, and I think you could find some specialized products within that. And so I think the rule is beginning to this proposed rule sort of recognizes that sort of in this sort of next era of health IT data exchange, it's not just about this monolithic payer solution or a monolithic sort of EHR solution, but that there's a recognition that health IT is going to be composed of perhaps many modules, and that naturally you want to sort of break down the requirements and the testing to sort of serve this sort of implementation and deployment model. And I agree with you. I think that that's going to open up other organizations that are building these applications and solutions to perhaps enter into the testing and certification market like they had not been in the past.
Yeah, and that also, I was also realizing that we haven't touched on the prescription drug side of this, which I mean, there's a revision to the current e-prescribing rule, and then there's actually a new criterion as well coming in for real-time benefit information, which is kind of separate from a lot of this fire-related stuff we've been talking about. But very interesting that the ONC has taken that on, I think that seems like an area where there's some direct consumer benefit, and trying to solve a real problem that exists today in terms of accessing benefit information in real time that affects a care decision.
Yeah, for sure. I mean, there is this sort of in this sort of long-term vision, to and I think it's an ongoing theme to sort of enable patients, get patients more involved in their um, uh, not only in the financial end of their health care, um, but just empowering them to be a participant in their own health care, whether that's through care coordination or, um, like you mentioned here with like the real-time pharmacy benefit. I think we can all have had an experience probably where we've showed up to pick up a medication, at our pharmacy, and um, are met with a cost of the medication that's exorbitant because our health insurance doesn't pay for it, and then that means a delay in a patient getting their medication while there's a call back to the provider to maybe prescribe something different, or a prior authorization action that happens. I think requiring the pharmacies and the AHRs to implement these new standards from NCPDP, that will sort of, at the point of care, providers will understand and know what the health plan coverage is for a particular med is, if prior authorization is required, if it's covered, and know ahead of time whether or not the patient can financially afford this particular medication, or some other therapy might need to be explored, and that's going to result in a better patient experience in the long run. And I think that's kind of this overriding theme of where we've been going with Fed regs, with health IT, and the HTI-2 rule. I think in many areas sort of builds on that theme. Is there?
And I wanted to mention, just for the EHR developers that are listening, that there are revisions to the existing e-prescribing B3 criterion, and then this real-time prescription benefit capability is under B4, and they both have a deadline of January 1, 2028. So when I think about what's coming in terms of work year by year, starting from today, decision support has been the theme of 2024. 2025, we have everything else that's in HTI-1 coming. That's due by January 1, 2026. Then in 2026, we have the prior auth rule, plus some changes to some of the public health criteria that customers may be certified to. And then in 2027, to hit that January 1, 2028 deadline, we have these e-prescribing rules coming in. We have the public health API and the provider access API all coming in that year. So it lines up what I guess now is basically about 3 years and 4 months of schedule ahead, assuming that these deadlines hold, in the final rule for HTI-2. And there are, I think, some other devils in the details here that we haven't touched on today, because we haven't completely absorbed all of the impacts and revisions, and actually haven't even talked about the fact that there's a new US CDI version that version 4 also comes in with a January 1, 2028 deadline. So end of 2025, everyone needs to be on version 3, and then 2 years later, they need to be on version 4. And I know we have some developers that are already looking at version 4 and thinking that maybe they'll skip version 3 and move to version 4, which is something that they're allowed to do. And it's one of the limitations we have right now is that not all the test tools are available and up to version 4. So we're hoping to see more test tools that are at the version 4 level so that we enable that flexibility for customers to move up to that data standard rather than having to go to version 3 if they want to move their product along now.
Yeah, and a lot of the IGs, that are referenced here in the rule haven't been even updated fully to even USCDI 3.
Yeah.
So that's going to be sort of a little bit of a barrier to going straight to USCDI 4. So I think it's it's an upgrade path that has to be managed. I think a lot of the developers are going to have to take long, hard looks at and have a good plan for how they're going to move. And I know that's part of what you do in terms of helping developers sort of chart that out and sort of understand these things. Bob, I know that you have sort of a long career history on the security side. Even prior to your work in health IT and health IT data exchange, what do you kind of see in the HTI-2 rule that sort of begins to push the envelope around security and
yeah, I'm glad you brought that up. It's another area that's interesting. I mean, I actually spent a lot of my career in the multi-factor authentication space.
Yep.
And it's nice to see that D13 will now actually require multi-factor authentication. And I think that has a January 2028 deadline on it, if I remember right. So instead of it being just a yes or no answer, we'll actually have a requirement for multi-factor authentication. And then it's interesting, there is the other rule, D12. I'm not sure if it's a typo in the rule, but it says 2026. And I think, I don't know about that. I'm kind of wondering if they intended both of those rules to be 2028 deadlines. But right now that could be the one deadline that's aligned with the other HTI-1 rule, or the 2026 January 2026 deadlines in HTI-1. Or maybe it's a signal as to how quickly this final rule is going to get out.
right.
So, I mean, what do you think about that? I mean, do you think we're going to see this final rule very soon?
Well, I think that's a really good question. I know the comment period, I think, is open until early October, first or second week in October. And I expect that there to be, because it's so thick, so meaty, so ambitious, that there will be a lot of comments that the agency will have to, sift through. So that could take a while to to sort through that and then sort of finalize the rule. I mean, I don't know. It kind of feels like, and this is just me speculating, Bob. I kind of feel like, maybe we could expect something, by maybe towards the end of first quarter of the next year. But that could get delayed too. If we have an administration change, I mean, this is an election year, right? As everyone I'm sure knows. But if we have an administration change, that's usually a big thing at the federal government level. And finalizing a final rule has to go through lots of reviews, different groups, different agencies within the federal government. That could all get slowed down and bogged down if there's, an administration change. So, I mean, it could even go, longer than that. But I think there's probably a lot of work to be done, to finally finalize the rule. So I kind of not really expecting to see the rule by the end of the year, by Christmas time. I think it's going to take longer than that. But again, that's just me, sort of, speculating. But I do think it's important for the rule to kind of get finalized as early in 2025 as possible, because as you mentioned, the deadlines on the CMS side for the payers will be coming, sooner than this rule. They have to get the fire infrastructure in place, for the EHRs and the providers to be able to connect to those APIs and use them. So there is sort of this, stair step of order of implementation that sort of has to happen, but you don't want the rule to drag on too long, because you need developers here in the EHR world need to know what they're going to have to do, and when they're going to have to do it. So I think there will be a push to get it out as soon as they can.
Yeah, I guess. I mean, basically, if it does come out in early 2025, or even by Q2, then there's about a year and a half to meet the prior auth deadline, and we don't really think that deadline is going to change because there's already a CMS final rule deadline out there.
Right.
Right. I guess the question would be is whether some details within those requirements change, which could affect development.
Yeah.
So we'll see. And just to comment on F12, I'm sorry, not F12, but D12, if that January 2026 deadline is correct, what it's going to require, it's the encryption of credentials and the hashing of passwords, which you would hope is mostly being done already. But if it's not, that could be the one deadline that's maybe 6 to 9 months out when this rule becomes final. So we'll see.
Yeah, that's true.
Well, I think we've come to the end of our time. Good discussion today, and thanks to everybody who joined us. As you can probably tell, we've barely scratched the surface of this proposed rule. We will be turning this topic of HTI-2 into a series, so keep an eye out on our website and on LinkedIn and in your inbox for details of future sessions that we have. You can visit our website or contact either of us using the information on the screen. And you can also book consultations with us by scanning the QR code that's on the screen. So we look forward to seeing you at our next LinkedIn Live, and thanks again for joining today. Take care.